Well, ladies and gentlemen, now we are heading to the third agenda today. It is HIV Symposium, and the moderator of this session is Mr. Adi Nugroho from Universitas Lambung, Mangkurat. Here it is the profile of him. Mr. Adi graduated from Faculty of Public Health Universitas Diponegoro, specialized in epidemiology and tropical diseases. He pursued his master degree at Master of Health Science from the same faculty, specialized in health promotion. He also gained Master of Health Science, specialized in public health from Faculty of Medicine and Health Sciences, Erasmus University, Rotterdam. Mr. Adi continued his doctoral degree, specialized in public health education and promotion from Erasmus University as well. Mr. Adi is having expertise on behavioral change interventions, community development program, monitoring and evaluation and implementation research with a demonstrated history of working at NGOs and in academic atmospheres. He is skilled in epidemiology, HIV prevention, sexual and reproductive health, gender mainstreaming, and health promotion. Well, ladies and gentlemen, it's now my pleasure to invite our moderator today. Please, the time is yours, Mr. Adi.
Thank you, committee. Ladies and gentlemen, distinguished guests, honorable speakers, good afternoon. I think this is already afternoon time, as we have our lunchtime sessions. Welcome to the Symposium 2 on HIV of International Conference on Tropical Medicines. Yeah, as we know that the global target, we have the global target of ending AIDS by 2030, which Indonesia is not an exception. And to make sure that in HIV response that we are on track to the target, there are sets of triple 95 to be achieved by 2025 to make sure that 95% of people living HIV knows their status, 95% of those that already know that to start the treatment and stay on the treatment, and the 90% of those that are not on treatment are getting viral suppressed. Indonesia now estimatedly has over 500,000 people living with HIV. And we know from earlier sessions that in terms of the triple 95 target, that Indonesia still a little bit far from targets according to the triple 95, especially for the second 95 and the third 95. And for today's sessions, I'm really delighted to have the opportunity to be chairing for these sessions, which we have three excellent speakers that already joining us. We have Professor Pande Putu Januraga from Udayana University, and Ibu Dr. Yanri Wijayanti Subronto from Universitas Gadjah Mada. Hi, Ibu Yanri. And also Professor John M. Kaldor from Kirby Institute, University of New South Wales. Without further ado, I think the same arrangement with our earlier sessions, that each of the speakers has 20 minutes of presentations. And at the end, we will be having a Q&A sessions for the three panelists. Without further ado, I would like to invite Professor Pande Putu Januraga from Udayana University, that today he will be talking about the effective strategies for community case finding and testing, which regarding the first 95 to bring people with HIV knowing the status. Professor Pande Putu Januraga is the professor at Department of Public Health and Preventive Medicine, Faculty of Medicine, Udayana University in Bali, Indonesia. Currently, he holds a position as the head of the Center of Public Health Innovations at the university, a research center focusing on developing and conducting innovative methods to overcome public health problems and issues in Indonesia. Professor Januraga also holds an academic status as a senior lecturer at the discipline of public health, Flinders University, Adelaide, Australia, And as a researcher, he has been focusing on developing public health programs and policies for Indonesia, especially for those that underserved, stigmatized, marginalized groups, and furthermore, delivering evidence-based public health interventions with his organizations, Yayasan Kerti Praja, a leading NGO in HIV program for key affected populations, mainly female sex workers in Bali and Indonesia. I think without further ado, Prof. Pande, the time is yours.
Good afternoon, everyone. First of all, I would like to thank you, the Committee of the Global Challenge in Emerging Infectious Disease Conference that hosted by the Pusat Infeksi Tropis Fakultas Kedokteran Universitas Gadjah Mada. As requested, I would like to share my thought on how to improve HIV testing in Indonesia. So as we know that to end the transmission of infection, we need to conduct the test. This logic is also applied into the HIV epidemic, where HIV tests will result into options. First, one is negative, hopefully negative. If negative, we could continue to health promotion program, where we could educate and also provide tools for the people, particularly the high-risk group, to have more safer behavior. Currently, we also have the new technology, the PrEP, the pre-exposure prophylaxis, that evidence from other countries that already implement PrEP is very effective in prevent HIV transmission that resulted in the decreasing in HIV incident in the population. If the test positive, we could continue to treatment, and antiretroviral treatment will provide us with viral suppression commonly after 6 months. And if undetectable, or the virus is suppressed and undetectable after 2 times undetectables, theoretically, we could say that undetectable is untransmittable. So the people could not transmit the HIV to other people. And also, with HIV test with positive result, we could introduce partner notification, where we could notify their partners and their children to also conduct HIV tests. So we could find the status, and if positive, we could continue with treatment. And if negative, we could then provide health promotion and also PrEP if needed. So this is really the first pillar to end the HIV transmission. This is the figure from the last 5 years of HIV testing in Indonesia. We experienced increasing in the trend, where in the last year we could reach more than 5 million people conduct the test with more than 36,000 new cases of infection. But we need to remind ourselves that half of this test is come from the pregnant woman. See, almost more than 2 million tests come from the pregnant woman. This applied also to the previous year. So half of the tests come from the pregnant woman. So actually, if we want to achieve the target of the first cascade, 90, or the first 90, or now the first 95, we need to really improve the test. not only among pregnant women, but also among other group of population. So this is the figure among pregnant women in Indonesia, where the trend is also increasing, except in 2021, quite significant decreasing from 2.4 million to 2.11 million. The prevalence among pregnant women from these figures is about 0.2%. So using pregnant women as proxy indicator, we believe that the epidemic of HIV is still in a low level in the general population. But the start treatment is only about 30% from the positive results. So we have a huge homework for this one. So actually, we already implement some initiative to improve the testing. But before I present that, I would like to also highlight the new MOH regulation about HIV prevention and HIV program in Indonesia. So this regulation, number 23 in 2022, just released a couple of weeks ago. It highlights the two types of testing: facility-based testing and community-based testing. So the facility-based testing is very normal in Indonesia, but this is highlight the role of midwife. So it states that the midwife could conduct the test because it conducted in the midwife clinics. So I will later on explain to you that why this is very important. And also this is highlight the community-based testing that could be done by the health professional, and highlight the role of non-health professionals such as outreach workers or community members as outreach workers as the test implementers, and also individual, or we call it self-screening. And in terms of the case finding, we have active case finding and also passive case finding. So I would like to continue my presentation on the lesson learned from the previous project on methods to improve HIV testing in Indonesia. The list is about the community-based testing and self-testing, and then support for partner notification, and also improving the roles of private providers in HIV testing among pregnant mothers. So this is come from our study that conducted in 2020 among female sex workers in 23 priority district in Indonesia. We have 15 district intervention arm, and we have 8 district in control arm. So we found that the introduction of oral fluid test as a community-based and self-screening contribute to almost 19% of the tests in the intervention arm. We also found that in the intervention arm, higher HIV reactive result compared to the control arm. This is particularly because of in the intervention arm, we found more new tester. So higher proportion of new tester in the intervention arm because due to the introduction of oral fluid test. So this is promising because then we could say that the test is acceptable by the group that previously refused the test. In terms of the cascade, we still face the same problem where the link to care is still not good. From the OFT reactive result, from the screening reactive result, the link to care for confirmatory test is only 70%. And then from the confirmatory reactive result that went to treatment is only 86%. So link to care after screening positive is still a homework for us. The second project still in the community-based HIV self-testing is the STAR3 project, conducted in 2021, 2022, led by Prof. Budi Utomo from Faculty of Medicine, Faculty of Public Health, University of Indonesia. This study facing the same problem, even lower confirmatory test is only about 50% from the reactive result received confirmation. So we lost more than 50% of them. And from the positive confirmatory, it's only about 60% that went to treatment or start treatment. So still the same problem. The good news in this study is because they introduced the self-testing to all of key population in Indonesia, so we could compare each other, and the positivity rate among partner of people living with HIV is really high, while it's also quite high among MSM and transgender women. Ministry of Health also actually scaling up this project using the global fund money. Until August 2022, more than 35,000 people get screened among MSM, transgender women, people injecting diuser, female sex workers. The percentage of reactive result is varied between 1.45 to 3.9%. The highest is among MSM. The same problem is the confirmatory test is still below 60%, while the initiation is still below, RT initiation is still below 70%. So we still facing the link to care problem. What we could learn from that project is HIV self-testing is actually highly acceptable by the community because they use it. We prove that they use, the community accept and use the test. Sorry, I put it wrong. Strong is not only among female workers, but among all group, the very strong preference to choose the community-based or assisted test. So they use the test assisted by the outreach workers, that we call it community-based testing. Probably because it is still new, because the self-testing is still new. The technology is new among the communities, and I believe based on the international experience, in years to come, probably more people will aware with the technology and willing to use the test in private, so the self-screening will expand in the future. So that's why then we need to prepare the infrastructure, particularly on how to record the result if positive, and how to link to care. With the assisted test, we still lost more people. So with the self-screening or self-testing, we need to prevent this. So we need to develop an infrastructure or model to link to care. The second project is support for partner notification demonstration site. This is also from our project in 2019-2020, where we introduced partner notification support for health providers. And we found that the cascade is also decreasing like this. Even though we able to have the test index, but the successfully conducted is below 70%, and the one that accepted HIV test is also below 70%, while the proportion of HIV positive among accepted tests is quite high, 20%. So we really need to improve the notification to find the positive case and start treatment for them. The good news in this project is we found that community referral and dual referral and also provider referral is quite promising, particularly in the dual referral and community referral, where the role of community is highlighted here. So they're very important to involve in the services. So what we could learn, we need to mainstream the assisted referral. Assisted referral could be conducted by the health provider and also could be conducted by the community members that help the health providers. And we need to really offer the assisted partner notification immediately after HIV diagnosis without further ado immediately, because delay will result in not testing. We also need to develop telemedicine procedure and process, because most of the test index was contacted by phone, and currently we in the system we don't have infrastructure for that. So in the project, most of the contact made by the health provider and community members using their own device. So we need to have a system in the health service itself. The third one is about universal HIV self-testing among pregnant mothers, where the roles of private practitioner is highlighted. A study from Dr. Wulandari among 70 midwives from private clinics in Bali suggests that we need more innovative strategy and implementation models to improve the result, because only 50% of the referral patients went to testing actually. So we lost many women that do not go for HIV testing. If we look at the capacity of the private provider, then a study by Adewaya et al. Found that the capacity of the private compared to the public provider is much lower. So we know that probably half of the women in Indonesia go for antenatal care in private sector. So we really need to improve the capacity of private sector to conduct HIV tests. And the current and the new MH regulation already highlight the role of midwife in conducting the test. So gap still exists in the delivery of PMT-CT that compromise the standard of care, including HIV testing, particularly in private provider and rural area. So we need to focus on the capacity of human resource in delivering the services, particularly among private provider and rural area. We need to develop better coordination and referral system. If we still don't able to provide the midwife with the tools to test, with the instrument to test, then we need to develop a better coordination and referral system from the private sector to public sector to conduct the test. And we, in the future, we really need to ensure the availability of infrastructure for universal testing in all kind of provider, private and also public. So what next to consider? I believe we need a model for expanding universal HIV screening using opt-out model. Why? Because from the SIHA data, we know that almost more than half of the new cases come from outside of key population. So we need to found them not using methods that normalize testing in any kind of health services in Indonesia. So actually, we already tried to use opt-out model in pregnant mothers, TB patient, STI patient, partners and children of people living with HIV, and partners of high-risk group. But the implementation is still varied and really influenced by the confidence and the capacity of the health provider. We need model on how to improve the ability, the competence and the confidence of the health provider to do this. And also we need to probably consider the other services, for example, emergency department or other hospital outpatient clinics in other setting, in hospital or in puskesmas. So then we could have more people tested. So opt-out testing in this setting, I believe, may reduce stigma associated with HIV by normalizing testing. And we need implementation research to understand ongoing barrier and focus on strategies to better integrate HIV testing into clinical workflow. So if we want opt-out model, we need a better clinical workflow, integrating HIV testing in them. So I believe that's all I could say in this meeting. The time also limited us. Thank you very much for listening. I hope this will open more discussion in Indonesia about how to improve HIV self-testing. Once again, thank you very much.
Thank you, Dr. Pande, for the presentations. And ladies and gentlemen, as you can see, the Prof. Pande's presentation was pre-recorded, but he is joining us for the Q&A session. So if you do have some questions, you can stay and keep the questions, and we will discuss to that in the Q&A sessions. For the next speaker, I think this is the follow-up for while Dr. Pande talked more about the first 95, how to expanding the HIV testing coverage with some modalities. And Dr. Yanri will be speaking about the strategies to increase treatment uptake, I think, especially on RT uptake for people living with HIV once they know their status. So Dr. Yanri Wijayanti Subronto is, I would say, a full package in this field. She is an academician, clinician, and also a researcher in the field of internal medicine for mainly in tropical and infectious diseases at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. She completed her PhD at Leiden University, the Netherlands, in the field of tuberculosis immunology, and is now a very well-known person in the issue of HIV/AIDS in Indonesia. She is currently a member of the International AIDS Society, the expert partner member of expert panel on HIV/AIDS and STI for the Ministry of Health, and served as the chair of the HIV/AIDS management team, also the head of the HIV polyclinic always at the Dr. Sarjiti Hospital, and the head of the HIV/AIDS working group at the Center for Tropical Medicines at Universitas Gadjah Mada. Currently, she is involved in the proactive and D2EFT research with supported by NIH and Litbang Kemenkes, Domino study, COP study, and which that all related to HIV topic. And yeah, Dr. Yanri also has been part ALMI since the inception and was involved in the preparing Science 45 book, especially in the chapter of health and medicines. Without further ado, Dr. Yanri, please take it away. Time is yours, Ibu.
Thank you,
Hi,
Mas
Ibu.
Adi. Hi. So Adi is a well-known person as well, and I'm very happy working with him. So good afternoon, everyone, or good morning for some of you, or good evening for some of you who is in Australia, maybe. Thank you, Adi, for the introduction. Well, I'm just me. It's a great opportunity for me to share or to be in this event. Thank you, Bu Egi. Thank you, Pak Doni, for inviting and be part of this important event. As Adi mentioned, my talk will be kind of a continuation of Prof. Pande. Maybe some of you are not yet working on HIV, so maybe some of the slides is a bit easy. Hopefully, it'll be easy to be followed up. My task is about the antiretroviral treatment uptake, which is actually the second issue in HIV. As we all know, in the world of tropical infectious disease is always that we have to find the person so we can treat, and then hoping that if we can treat them well, we hoping that we cut the transmission. So these kind of my points of discussions. I will highlight the epidemiology of HIV, particularly on the cascade of HIV, and then how to initiate or strategies to initiate antiretroviral therapy in the sense of my analysis as being a clinician and reading the publications and all. So what things to consider, and then what we can do at the end in the community. So from the clinical part and then going into the community. For some of you who might be new to HIV, HIV actually already this year is a 41 years of HIV, because it was then, so to say, discovered or internationally known or proclaimed in 1981. So last year was the 40 years of HIV, and now is the 41 years. And up to now, or until now, there are 38.4 million people living with HIV throughout the world. And then, well, because that's accumulation. But then, thing is, there's the data at the left here that the new HIV infection in 1 year is still, so to say, still 1.5 million, even though this is already reducing so much since the first epidemic in 1990s, the 20s, the year 2000s, and now. But still, we are actually, the world is leading towards ending HIV. So the target will be only, so to say, only 500,000 new infection a year. That's what we aim for. And then deaths due to HIV or death to AIDS is, so to say, still 650,000 a year. Again, we are aiming for 500,000. So that's so much for what it is in the data, the whole thing. But then we see a bit in the who is infected or who are those infected. If we see there are three pie chart here. The left one is the global. For the global, the 30% is remaining population. So these are the ones who are not belong to the other, so to say, key populations, which are sex workers, which is in here is 12%, and then people who inject drugs, which is 10% here, and then 21% is gay men and other men who have sex with men. Transgender women is only 2%, and then 25% is client of sex workers and sex partners. But then if we break down from the sub-Saharan Africa and the rest of the world, it's a bit different. As we see in the sub-Saharan Africa, it's more noted as the 49% is the remaining population or the general population, so to say. And then the rest of the world, we still see 41% is gay men and other men who have sex with men. I want to highlight this because when we are considering about antiretroviral therapy, one of the things is that we also have to consider who is the person that we treat, from which populations or in the community. So we have this, let us all going to ending AIDS in 2030, which at that time point, so to say, by 2030, 95% of people living with HIV know their HIV status. This is the task of Pande just now. This is what we aim for. And then now is kind of the second 95% is those who already know their status, which is HIV positive. They should receive treatment, because if they receive treatment, we are hoping that they are virally suppressed, so the transmission in the community would be much less and less. So then, so we are minimizing the new infection and then ending AIDS. But then what happened? That was the goal, 95% and all. But then this is what we achieved so far. what we achieved so far from the first 90 or 95 is still 84%. So if we are going to reach the first previously it was not 95% the goals. The target was 90. So if we were going to reach the first 90, actually we are still cap of 2.5 million for testing. But if we were aiming for 95%, then we still have additional 1.9. That's the testing. And then the second graph is the cascade of the cascade is who are supposed to be on treatment, which is only 73%. And then we still need 3 million to reach the 90%, and then another 3.4 million for reaching the 95% target. So, okay, this is our homework now. What do we have to consider now? That means we still have a gap. We still have a problem on treatment uptake with various reasons. Either social stigma discrimination is still around, and then other things. But I will not go into the stigma discriminations. I want to go into the clinic now. What do I have to consider when I'm going to start an HIV treatment for a person who comes to me? Okay, I have to think about the clinical stage, and then whether particular on the clinical stage is the presence of tuberculosis, and then I have to understand all the medications that I have or don't have, and the risk of toxicities, and then simplifications of the clinical procedure to one that would suit the person, so they would drink the medicine as we ask, or they would adhere to their own treatment. Just to review for some of you are working on HIV world, we have this HIV clinical stage. There are stage 1, 2, 3, and 4, which is at stage 1, symptomatic, asymptomatic, and lymphadenopathy, generalized lymphadenopathy. And then the second stage will be weight loss, 5 until 10%, sore lip. So these are the second stage, usually goes into the dermatovenerology specialist. And the world sees, from my experience in the clinic, the past 8-10 years, we are seeing, which is a good sign, is that many or more people are coming at stage 1 and stage 2. So they are not ill yet. Being ill means at stage 3, where they have the pulmonary TB, diarrhea, weight loss, and other things, or anemia, or the recurrent pneumonia, etc. Stage 4 is usually going into the neurology specialist with the extrapulmonary TB, might be in the brain, toxoplasmosis, cryptococcal, or CMV in the brain, and all of that, or in the eye. So our knowledge now is start antiretroviral treatment independent of HIV clinical stage, independent of the CD4 counts and the viral load. So no matter the clinical stage, we have to think about starting ARV. But then what else do we have to consider? Presence of tuberculosis, I put it specifically. TB or not TB is always the question. Why? There are 3 points that I would like to share with you, that TB and HIV interactions is dangerous. It's like fuel and fire. So it's always destroying each other and making one another progress into worsening of the disease. Secondly, it has impact on the course of treatment. So if you have TB, and then you have to start thinking, this is the anti-tuberculosis first that we have to put in. If there's no TB, we should put in the antiretroviral first. Thirdly, also the implications of tuberculosis prevention treatment for those who doesn't have TB. So if we are facing the HIV, please find out whether there's a tuberculosis or not, particularly in, like us in Indonesia, which is one of the high burden country for TB. How do we know whether it's a TB or not TB? We have a screening tool actually. This is, I think this is already internationally accepted as well. Cough, subfebrile, and then weight loss, night sweat, lymphadenopathy, TB contact. Just ask this as frequent as possible. If there is a yes, then you go to the TB examinations. If there is a yes in any of one of these, or any or one or other, or more than one. If there's if all of these symptoms are known, then you can start TPT, the tuberculosis preventive therapy, and then you can also start ART because you don't have to start with the ATT first. If you find symptoms and then find out whether it is really TB, then you start anti-tuberculosis first. So that's two things, HIV clinical stage, the TB itself, and then antiretroviral therapy itself. Actually, antiretroviral therapy has been described since the early 90s, I guess. First PI approved was in already 1995. First NRTI, first drug approved for treatment was Zidovudin in 1987. So it's already kind of a quite long journey. And now that we have this, the world is changing into, or the world is going into a more simplified. And then now we are a lot of using dolutegravir as one of the backbone. And then we have now here in the left is the picture of the combinations between tenofovir, lamivudine, and dolutegravir as one of the most recommended drug for now. Why is it? I would like to take you back to a bit of the evolutions of clinical recommendations in the WHO guideline for ART over the 10 years or more now, almost more than 10 years by now. When to start? At that time, we think that it has to be below 200, and then we move it into below 350, which is 2006, and then below 500, and now it's straight off. That's the evolution. And then preferred first line. At first, it was AZT because there was available, and now that we go into the fixed dose combinations. At this time, until 2013, this is the Dr. Vittoria paper. At that time, we still have the tenofovir, lamivudine, and efavirenz. And then preferred second line is this. So we can you can all read this. I just want to highlight with you that there is evolutions on ART regimens. The reason why it evolves is that we have to think about adherence of the patients taking it. So we have to make it as simple as acceptable for all of them. So optimize drug regimens, if it can be, if it's fixed dose combinations, and then if we have if we can provide point of care diagnostic, so we can have a same day treatment, test and treat, or a one-stop service, it would be much more beneficial for those who need it. And then can it reduce costs? So we have fixed dose combinations, and then we can dispense it as a multi-month dosing, so they can come 2-3 months instead of per monthly. And then decentralization, meaning community ART delivery. This is something that is in the air, but it's not all fully implemented in many countries. Also in Indonesia, there's a few things that we still have to consider how to put ART in the community. So this is the one that I mentioned. Combinations that in Indonesia use is the 2 NRTI plus 1 NRTI until 1 year ago, and then now we have used the 1 integrase inhibitor, which is the dolutegravir. So if we see these drugs, I would like to go the several characteristics of the drugs that is being used as kind of the initial treatment. Tenofovir, they have a renal toxicity, but it's rare. And then efavirenz, there is a CNS toxicities, so that's why risk of dropout. They go into hallucinations. They go into central nervous system symptoms. Sometimes they stop their own medication. But using tenofovir plus lamivudine and efavirenz can be used in many populations. It is safe for pregnant women. It is safe for TB, hepatitis, and other key populations. Only that some will not work with the efavirenz because, like sex workers, they will not be able to take it at night as we ask, because we want to reduce the CNS symptoms. So we have to think about dispensing efavirenz. So the dolutegravir comes into the answer, which can be used in all the populations, which is safe. There's less toxicity, less side effects. Given that, So we have to think about strategies to immediate ART uptake. Based on our experience in the HATI study, HIV/AIDS Test and Treat Indonesia study, which was also being with Professor John Kaldor and Prof. Pande, it was a longitudinal implementation research in 4 cities, Jakarta, Bandung, Jogja, and Denpasar. It was aimed, the whole HATI study was aimed to develop intervention to improve HIV cascade of care. And then one of which is the simplifications of ART initiations, which is to improve ART uptake. Uses simple screening form to distinguish those eligible for immediate ART or not. Like this. So we have this screening form. Is the patient over 50 years old? Yes or no? Is the patient having a BMI of under 18 or above? Do they have TB symptoms like the one that I already mentioned earlier? Do the patients have history of diabetes? Do the patients have hypertension, have a kidney diseases, or are they at clinical stage 3 and 4? So from here, we can say, is the patient eligible for rapid ART initiations? What do we want? What do we want is that these questions actually refer to the toxicity or side effect of the tenofovir, especially the age, the BMI, and then also because I was mentioning that tenofovir might have interference with renal function. So any diseases which might interfere with kidney function, like diabetes, hypertension, or other kidney disease, we have to screen first. We can use screening simple anamnesis like this. So we are hoping all of this is no. If all of this is no, this person is eligible for rapid ART initiations. As I mentioned, the last 10 years, we see many more patients coming at stage 1, at maximum of stage 2. So they are actually eligible and they are young. So they don't have many chronic diseases. They don't have hypertension. They don't have diabetes. And they are still in a very good situations. So this was the HATI patient flow. After using the screening tools in the middle here, if it's eligible, then we start. We can start at that time we still use the evaporants, but even though if we change the evaporants to dolutegravir, it's still okay because all the screening form was mainly for those related with tenofovir. So at this time point, we have to have all the lab. If we are using that combinations, actually we don't really need to have all the pre-ART lab testing, because we are only seeing tenofovir as the one who has might imply to laboratory of the kidney function. So we can move the creatinine level testing after we start, and then we can continue. So this is kind of our study. We are preparing for publication, so that's why I don't want to put it into much more detail. I have 3 more slides, I guess. If we are already working on the clinical side, and then we have to think about the public health purposes. If we can simplify the clinical procedure, hopefully we can move it into the community-based, especially if it's not the community with the really community, meaning that we can use it at the primary care level because it's already that simple. And it's and then we can use this. We can scale up for any opening for primary care can use the procedures, the one that I just mentioned. So in conclusion, one of the main problem in HIV control is the persistent transmission in the community. So that's why the number is still increasing. There is still a big pool of people who maybe does not know that they are HIV positive, so they keep on the transmission, or those who are already know they are HIV positive, but not yet starting ARV immediately because other procedures, they have to go there, you have to refer it, you have to go to other hospitals, blah, and other various reasons. So I think the third point is simplifications of clinical procedure for antiretroviral initiations is one of the main strategies to increase and speed up ART uptake. And of course, simplifications then can be scaled up for primary healthcare for public health purposes. For this, I thank you. Terima kasih and matur nuwun. I return it to Mas Adi. Thank you.
Thank you. Terima kasih Bu Yanri for the presentations. Yes, I think it's it has been really a challenge while ART medication is provided free by the government Indonesia, but still we do have a big gap in achieving the target of 95% due to some structural barriers, social barriers, and so on. And that you highlighted about the needs of simplifying the clinical procedures and also expanding into the some modalities of RT deliveries. I think it's something that has to be discussed and considered for the country. So I believe we will go to in more deeper later on in the Q&A session. So for you that have questions, please do utilize the Q&A box to put your questions there. And for now, I would like to continue to our last, but of course not the least speakers, Professor John Kaldor. She will be speaking about the control of sexually transmitted infections, the current status and challenges. When we talk about HIV, of course, we cannot separate this with STIs. For many reasons. The two reasons that I know is, of course, it will be STI will put people more prone into HIV infection, and also for those that are using PrEP for the pre-exposure prophylaxis, it can compromise the effect of the PrEP. So Prof. John Kaldor, I'm really happy to. I mean, I've been knowing the name for I don't know since I can remember, but having Prof. John Kaldor is here is really a privilege. So Prof. John Kaldor is the senior principal research fellow, and you end up. Pardon my pronunciation. UNSW Scientia Professor. He holds a doctorate in biostatistics from the University of California, Berkeley, and began his research career at the International Agency for Research on Cancer in Lyon, France. For over 30 years, he has built and led internationally recognized research program at UNSW on the epidemiology and prevention of infectious diseases. His research has covered a wide range of projects, including the development and implementation of public health surveillance systems, investigation of infection-related cancer, cohort and cross-sectional studies of risk factors for infectious disease transmission, and interventional trials of disease prevention strategies. He is also the past president of the Australian Epidemiological Association and currently serves as a ministerially appointed member of the Repatriation Medical Authority. Without further ado, Prof. John Kaldor, please take away. Time is yours.
Thank you very much, Adi. Can you hear me okay?
Yes, loud and clear.
Okay, that's lovely. Thank you for your kind welcome. I realized I should have updated my bio because our program is now called the Global Health Program. As of the start of this year, we now call it a Global Health Program. So that's reflecting our many collaborations in the region and certainly with good friends and colleagues, Ibu Yanri and Prof. Pande, who I feel like I've known both of them for a very long time. And in fact, I have, and we've been working together on many projects, and particularly the HUTI project and other training and research collaborations. So my only regret is that I can't join you in person this time in Jogja, but I hope that that will happen in the near future. Now, could I just check? Am I able to control the slides, or do I have to have somebody else?
I believe you can, Prof.
I'm not sure. Are they going to come onto the screen? How do we get them onto the screen?
Sorry. Have you tried to show your screen?
Oh no, I said no. I can share this my own screen. I thought that somehow they would be. Sorry, I'm a little bit.
Oh,
unsure. I thought that they would be putting them on the screen. I would share them.
The organizer, would you like to?
I can share the screen. I can share my own screen.
Sure.
I can do. That's fine. And I can just.
Sure, please do. Yeah.
I'll just.
Yeah.
See if that's happening. Sorry, that's.
Yes.
That's not.
It is showing now.
That's not okay. The screen is showing. I'll just have to bring my presentation over, and put it into presentation mode. Okay, I think we're good now, are we?
Yes. Yeah.
Okay.
Yeah.
All right. So my focus, as you mentioned, is going to be on the sexually transmitted infections, the current status, and what may be the important challenges. And there is a very strong overlap, as you mentioned, with HIV. This is first slide is a quotation from the WHO's plan, the strategic plan for STIs, which is now STIs is now packaged up with HIV and viral hepatitis in that department in the headquarters in Geneva, and you can see that there's a very ambitious vision, which is 0 new infections. That's a pretty big ambition when you think that there's hundreds and millions of infections every year, and the goal is to end sexually transmitted infection epidemics as major public health concerns. And they're talking about targets, which is a 90% reduction in syphilis incidence, 90% reduction in gonorrhea. Now, I think any of us who've worked on STIs would realize that this is a fantasy, that this is not likely to be achievable with any of our known technologies. And we really have to think, what are we trying to achieve with STIs? And I think one of the real challenges with STIs is to put them on the agenda, to understand why they are important. And in fact, for many, many years before HIV came along, they probably were not important, or at least they were ignored. And then HIV came, and I think we remembered that STIs may be important for a number of reasons, and you've already referred to some of them in your introduction. First of all, let's think what we have available as strategies for STI control and how effective these strategies might be. Well, for HIV, which is, of course, an STI, HIV is the big STI, we now have very effective strategies. In fact, ironically, HIV was the most frightening STI, and now it's potentially the most preventable, because we have the strategy of test and treat, so we reduce people's viral load to undetectable and then they're not infectious. We have PrEP strategies, which are incredibly effective at preventing sexual transmission. And also in very high prevalence settings, we have male circumcision, which can further reduce the risk of men acquiring HIV. For HPV,
Professor,
we have. Sorry.
Excuse me. Sorry to interrupt. Your presentation doesn't seem to be moving. Perhaps.
Oh.
Yeah.
That's strange. It's moving for me.
Okay.
Is it moving now?
You have to. Not on my screens. I'm not sure, but yeah, I think it's not moving.
So you're still seeing the first screen?
Yes, the title, and it's not in the slideshow mode. So perhaps you can.
It's definitely in slideshow mode here.
Yeah, perhaps you can stop share screen first and then re-share again. So maybe that would work. Sorry about that.
That's all right. It's a little bit mysterious, but I'm not sure. I'm not sure.
Now it's moving. It's
catching up.
It's working, but it's not in the slideshow now. Yes.
Is it working now?
We are now on the slide available strategies for STI control, if that's the correct one. Yeah.
Yeah. Is it advancing now?
Yeah. You can go. You can continue.
Okay, but does it say what do you see now? HIV? Do you see HIV and STIs?
Fileable strategies for STI control. HIV,
no, it's
HPV.
It's not working still.
Okay.
Let me just see. What can you see now?
Still the same, sir.
Oh.
Yeah.
That's
now. Yes. There we go.
This is not in presentation mode, but maybe I should just continue with. I'll try and just continue like this, because then you can see everything.
Yeah.
Okay. So we have the available strategies for HPV, which is this fantastic vaccine. For herpes simplex virus, we have no vaccine despite many years of effort. So we need to only treat symptomatically, and there's not a very successful strategy. Now, for the bacterial STIs, we have, in many countries, we have the test and treat strategy. But in many other countries, we have what you might think of as just treat. And that just treat may be using the syndromic method where we look at syndromes. We don't test to see which is the exact pathogen, but we just test on the basis of symptoms. So this is a strategy which has been proven to be rather insensitive or inaccurate in a number of settings. We also have the strategy of sexual behavior modification, including condom promotion. So you can see that we have a number of strategies here for STI prevention, but they are probably not as well studied or nearly effective as we have for HIV. So this is a real turnaround since the HIV epidemic, when we first thought that with HIV, all we had was condom use, but now we have so many other tools. And the story which connects HIV and STIs is a very complicated one. It was really only in the very first years of HIV's discovery that we discovered, yes, this is a sexually transmitted infection. And there was some case reports which showed that there was a connection between two people who were in a couple, and one had HIV, then the other partner had HIV. And that was a realization that this was a sexually transmitted infection. Now, by the 1980s, late 1980s, there was a realization that perhaps there is more to the story, not just that HIV is an STI, but perhaps the other STIs are causing HIV epidemics. And there was a lot of research, particularly in Africa, which tried to find a link between people having other sexually transmitted infections and HIV. And by the mid-1990s, there was a study that was very influential. There was a trial in Africa, in Tanzania actually, called the Mwanza trial, which showed that if you could control STIs, you could actually reduce the incidence of HIV. And this was very, very exciting because it meant that we had really the first strong tool, because this is before antiretroviral, before U equals U, before PrEP. So this was the first real biomedical strategy to control HIV. But sadly, by the mid-2000s, there had been no replication of this finding, and several trials had taken place in Africa where they'd used STI treatments very strongly and did not reduce HIV. So this was a big debate that went on for many years. So we still don't really know whether controlling STIs can control HIV. So we have to think, well, what is our main goal in control? Why are we controlling STIs? And then the other point, which Adi's already made, is that when PrEP was introduced in many countries, there was more concern because it started to increase the number of STIs. So we started to have concern about the role of HIV PrEP, even though it was very effective in prevention of HIV, it was potentially causing more STIs. But nevertheless, we see there are very clear links in the service provision for HIV and STIs, because they really require many of the same skills, the sensitive skills for clinicians about discussing sensitive matters. They do share some population control strategies, and we'll come back to that. And they may even share some clinical solutions, but I think we're still learning about that. So what about this link between STIs and HIV? Well, there have been a number of meta-analyses or systematic reviews, and this is quite an old one, but it really made the point quite clearly that for some STIs, and particularly for this one, genital ulcer disease, there seemed to be the many studies seem to show a very clear association that STIs were increased, that people who had HIV, there was a very strong association between having STIs. A little bit weaker for some other conditions, herpes, but herpes, there was only a few studies, but it seemed to be quite a strong effect. You can see this is the line of 1, which means there's no relationship, but you can see the few studies that were done back in these days did show a strong relationship. And the mechanism of the relationship, why STIs might actually cause HIV, was largely considered to be one of increasing the HIV viral load in the genital tract. So there was a number of studies done, and this is a meta-analysis from about 14 years ago, which showed that if you look at the people who had genital tract infections and HIV, compared to the people with who did not have genital tract infections, that there was an increase of shedding of HIV in the genital tract. And that was particularly strong for gonorrhea, also to some extent for chlamydia, maybe not so strong for bacterial vaginosis. So these did lead to a very strong view that STIs were important for HIV control. But as I said, a number of trials in the late 90s, early 2000s really were quite disappointing and showed that there was probably not much purpose to controlling STIs if your target was HIV. However, we have to think that STIs may have other important implications for health. And the focus then shifted much more to the reproductive health outcomes for STIs. And those reproductive health outcomes come from two directions. First of all, there's the direct impact in adults, which in women can cause pelvic inflammatory disease or ectopic pregnancies if it's the bacterial STIs. And of course, human papillomavirus causes cervical cancer. And then in men, there can be a number of systemic illnesses, epididymitis from gonorrhea and chlamydial infections. And then I think the aspect which has really raised concern in more recent years has been the potential for STIs to cause adverse pregnancy outcomes. And so we're involved in a very large trial which has just been completed in Papua New Guinea. It's the first trial in the world to randomly compare women who have been tested and treated for STIs in pregnancy versus women who are just following standard of care, which is that if they have a symptom, then they can be considered for treatment under the syndromic diagnosis. So we've now followed up thousands of women, and we're in the process of analysing those data. So it'll be the first time we can really provide a clear answer to that question. But as I said before, the trials of STI control for HIV prevention, the very first one was Heine Grosskirch, 1995, and you can see there's a reduction of about 40% HIV incidence in that trial. This was so exciting, but then every trial since then has just been not significantly different from the 1.0 line, and so there has been great disappointment on that strategy. So I shouldn't say we should forget about STIs in relation to HIV, but the focus of STIs has been shifted much more towards other dimensions. Now, if we look at the reverse situation, now we know that in the Asia Pacific countries, HIV PrEP has been adopted in varying degrees. And if you look at the map on the right, the number of people, this is in 2021, you see that the only country that's really adopted on a big scale is Australia, where we have many tens of thousands of mostly gay men taking pre-exposure prophylaxis for HIV. In other countries, Thailand has picked up some PrEP, but you can see Indonesia very limited or no use of PrEP, and some more limited use in other countries. And Australia still remains, I think, the only country with a national program in our Asia Pacific region. But one of the issues for PrEP is, as I said before, does this actually increase the risk of other STIs in our communities? And there were some early studies when PrEP started that showed an association between having sexually transmitted infections in people who are using pre-exposure prophylaxis for HIV. But then through a number of longitudinal studies, and this was some work conducted by our colleague at the Kirby Institute, Hamish McManus, and published a couple of years ago, it looked like the people who were starting PrEP, they had high levels of STIs, certainly, but when they started, it didn't really increase. They were actually, as they were approaching the start of PrEP, it seemed like they were getting ready to be more at risk. But once they started PrEP, there was no further increase. And in fact, a little decrease here in some of the indicators, the anorectal STIs. So we're starting to get an impression that it's not so much that STIs, not so much that PrEP increases the risk of STIs, but probably the true story is that people who want to take PrEP are people who are having more risky behavior in general, and they are already at risk of STIs. So it's not that you're getting an extra boost of your risk from the PrEP. It's more that you're already a person who's taking some sexual risk, and this is what's happening to you. So maybe that we can be a little bit less concerned, and maybe this can help to support the uptake of these PrEP strategy in some some countries that are a little bit slower. Now, we should talk about the success stories in STI control, because I've been talking about the difficulties, but actually there have been some success stories. And in fact, some of them are quite historical stories. There was a disease known as chancroid, which was a very nasty ulcerative sexually transmitted infection, which was very common particularly in the US and other Western countries in the 50s, 40s, and 50s. But then when good antibiotics became available, the chancroid, which is caused by Haemophilus ducreyi, became very easy to treat, and it really started to disappear. Now, it did come back a little bit during the HIV phase, but then has disappeared again. And you see very similar data from Africa, that in the 1980s, there were very high rates of chancroid in southern African countries, but then the access to good antibiotics, particularly drugs such as azithromycin, have had a very strong effect in reducing the incidence of chancroid. And we had a similar experience in Australia with another terrible ulcerative disease. This is a disease called donovanosis, which was very common in a number of countries of Melanesia, but also in Aboriginal communities in parts of Australia. We had very high rates, and this is a very, very debilitating ulcerative STI, which can actually destroy the genitals and are highly stigmatizing, because people have these continuing very florid infections. But when azithromycin became available, which was in the late 80s, early 1990s, it was recognized that the course of azithromycin could absolutely eradicate this disease. And we've really essentially, it's one of the few diseases that we've truly eliminated from our population in Australia. So that's a real success story. I'm sorry, I've got the same slide twice. That's a success story for Australia in control of one particular STI. Another example that I think you'll probably be aware of is this is a coincidental success story. So when the 100% condom programs began first of all in Thailand and also in Cambodia and other countries, when the HIV epidemic was looming in the late 1980s and the 1990s, the condom promotion program was actually very successful. As the condom use went up and up and up, the number of STI cases went down very dramatically. This decline was not sustained forever, but certainly you could see that condom use had a very clear effect on reducing the rate of sexually transmitted infections in this Thai population, in the sex establishment users. And then I think one of our most dramatic public health success stories that you'll be aware of is the success of the HPV vaccine, which is the ability to essentially eliminate one of the major causes of cancer in women over many countries for many years, which is cervical cancer. And this is a meta-analysis which showed that in young women, comparing the before, the ones who, the red is the women who are 5 to 8 years after the vaccine, and the blue is the ones who are 1 to 4 years after vaccine. The prevalence of HPV infection in these women has been radically reduced down to about 20 or 30% through the vaccine. And this is the high risk HPV types. And this is a very good indicator that in the future, these women will be protected from cervical cancer. And it is certainly one of the great success stories. What is less, and you can also have a similar story if the countries use the quadrivalent vaccine and have had very good success in reducing the incidence of anogenital warts. Now, across the world, this is another case of inequality, of the injustice of health. You see, all the rich countries and some of the middle-income countries do have good vaccine programs, but in many parts of the world, and particularly African countries, and these countries have the highest rates of cervical cancer, we see very limited uptake of this, or no uptake of this vaccine. And there's a very strong relationship, as with many aspects of health, that you see that the countries that have moved HPV vaccination to the national schedule of the African countries, this is a little bit out of date, but if you compare the high-income countries, 82% had the HPV vaccine in their schedules by this 2018. Low-income countries, only 13%. But these are the countries where the vast majority of people with cervical cancer are living, or at risk of cervical cancer. So you need these vaccines. Now, for herpes simplex, as I said before, we don't have any prevention tools, and this is now already a disease, a sexually transmitted infection that we just accept as going to be on a very large scale, and we just have to deal with the morbidity associated with this disease. Around the world, the numbers of curable STIs is very striking. So the numbers are in the tens of millions. These are infections that are very, very common, and these are estimates that the World Health Organization produces based on really quite limited data, but they come up with numbers that are really among the most common infectious diseases around the world. The question is, what are we really going to do about it, and what should we do about it when we're faced with such numbers? And for some of these infections, so these are including chlamydia, gonorrhea, syphilis, and trichomonas. These are all bacterial infections which are curable with a single dose treatment. You don't need to have complicated treatment, long courses of treatment. You don't need to have expensive drugs. They're all treatables by very readily available in either mostly oral drugs, although injectables are still used for syphilis. Unfortunately, that's not ideal. And gonorrhea in some countries, injectable drugs are being used, but still single dose treatment is the way to go. But we are still seeing increases in some countries with these curable STIs. So syphilis increased in many countries among MSM, among men who have sex with men in the early 2000s, essentially as sexual behavior, risk behavior increased in following the availability of effective treatments for HIV. It was seemed to just follow almost directly. But we've also seen in some countries that in antenatal positivity that there was big declines in early decades of syphilis in pregnant women, but we've seen some countries having a resurgence. And certainly in Australia, we've seen an upswing in the number of cases of syphilis, but also congenital syphilis. And so even though syphilis is entirely easily curable, if women go through pregnancy and not treated, there's a very high risk of severe harm to the newborn, or in fact of even threat to the newborn. So we are seeing what we should not see with a very severe outcome such as congenital syphilis. And again, there's a lot of variety around the world in the estimates of the proportion of women who are positive for syphilis when they come to antenatal clinics. And
Prof. Kaldor?
Yeah.
Excuse me. Sorry, you have 2 minutes for the presentation. Just a reminder.
Can I take 5?
Yeah, sure. Yeah, 5 is fine. Yeah.
All right.
Thank you.
So I want to come back to some important points. So there is a lot of inequality again with syphilis positivity, and this comes down to we see in many countries, and I think Indonesia is a country that maybe fits this, that the proportion of women being tested for syphilis in pregnancy in many countries is far too low. So the antenatal test, Southeast Asia is surprisingly one of the lowest places for testing for syphilis. And if as Prof. Pande mentioned, we really have a long way to go with HIV testing in pregnancy. I think we have even further to go for syphilis testing in pregnancy, which is a really crucial marker of a health system's capacity. Now, I'm just going to jump into to conclude and sorry, Adi, for going a little bit over, but I'm going to just in the last 3 or 4 minutes, I'm going to talk about 3 new directions in STI control. First of all, we know that in most countries around the world, STI testing is not done routinely for these curable STIs. And one of the reasons is the lack of standardized, centralized laboratories that provide high quality testing availability. However, recently there's been a move towards point of care testing and very simple to use point of care testing. And so we have, through that mechanism in Australia, we've, in our remote communities, in remote Aboriginal communities, established over 100 sites for doing point of care STI testing using the Gene Expert machine. And these machines were now being adapted for use with COVID testing as well, but they have provided a service. And over the last few years, we've seen a very strong increase. So we're now testing tens of thousands of women and men in these remote communities with these point of care tests, and the advantage here is that they can get a result immediately and have the treatment. Whereas in the past, they had to wait days, sometimes weeks to get the result back. So, there is a very big move in technology with the point of care testing. So the Gene Expert was introduced for chlamydia, gonorrhea, and trichomonas in about 2014. The technology has been improving, getting smaller, getting faster, and it will be not that far away that we can actually use this technology for really making sure that access to testing for pregnant women and particularly, but also other people at risk of STIs is in the clinic. And another advantage is going to be, it's going to really assist with our ongoing surveillance programs for gonorrhea antimicrobial resistance. This is a map from a paper that we published recently in the it was actually published in the Euro Surveillance Journal, and you can see that many countries do not have a proper surveillance system for gonorrhea antimicrobial resistance, and Indonesia is one of those countries. But we feel that if you can use the Gene Expert to detect cases of gonorrhea and then refer them quickly once you found a positive case for antimicrobial resistance testing, this could really make it much more feasible to do surveillance. So we've been discussing these plans with Prof. Pande and other colleagues, and hopefully we'll start to introduce them in the future. And the final point I want to make is maybe quite a controversial one. Oh, sorry, two final points. First of all, as you know about PrEP for HIV, but now, of course, there is PrEP for using doxycycline for sexually transmitted infections. The publication from Dr. Molina's group from France in 2018 showed that the people on doxycycline, this is post-exposure prophylaxis, had lower rates of chlamydia and syphilis compared to the people who didn't take this drug. And then this year at the International AIDS Conference, a similar finding was produced by a group from San Francisco. So we need to think about the applicability of this strategy and how it's going to take its place among the strategies for preventing sexually transmitted infections. And then my last point is the possibility of using what is called mass drug administration. So in some parts of the world, and this is particularly in countries of the Western Pacific, Papua New Guinea, Solomon Islands, Fiji, we have prevalences among pregnant women that are very high of chlamydia, 22, 29%. Most recently in Fiji, we found 34% prevalence of chlamydia, 9% of gonorrhea. This is very, very high and puts the newborns at risk. So the strategy that we've been thinking about in these settings when the prevalence is so high is that we should consider mass drug administration, which is when you treat the whole community, not just the people with the infection. It's maybe sounds controversial, but it's something which we are putting on the table and discussing actively with our colleagues in the Pacific. It's been tried once before, but the findings have been a little bit controversial. But there was one study in the Solomon Islands where this was a mass drug administration using azithromycin for a trachoma, but they measured this is before the azithromycin program, and then after, the chlamydia prevalence and the gonorrhea prevalence dropped very sharply. So the blue to the red, gonorrhea dropped by about 50%. But this was not a program for STIs. This is a program for trachoma, but then they measured the prevalence of STIs before and after. So this is an exciting new opportunity for very high prevalence countries. Just to conclude, and because I'm very keen about things like surveillance, just to say that we need to know more about STI occurrence. Our data on STI occurrence is quite weak in many countries. We rely on these very crude World Health Organization estimates, but we need to know where STIs are occurring, where are the hotspots, who's getting it, and then we need to know whether things are changing. We really don't have good ideas about what is the impact of our control strategies. And also we need to have better measurement of how our programs are working. So I apologize for going a little bit longer, and I really appreciate the opportunity to join, and thank you to the Institute of Tropical Medicine for this opportunity. Thank you.
Thank you so much, Professor Kaldor, for the very comprehensive presentations. And I apologize for rushing you a little bit. We do have a limited time for the presentations, but yeah, we a little bit behind on the schedule, but we do have several around 10 minutes time for questions and answer. So I would like to invite the Bu Yanri and Prof. Pande again to be in the positions to answer the questions. If you have, I think I'm trying to look at the questions here. I think we have one question first. It's addressed to Dr. Pande, Prof. Pande. So, apart from the confidential issues that you mentioned earlier, what is your opinion regarding the recording and reporting of HIV testing, HIV self-testing? Is there any effort that can be made to prevent the data loss so that the treatment can be done properly? I think this is regarding the linkage to care that we have the gap, the data that you showed, gap to link to the care or confirmation tests for HIV testing. Yeah, Prof. Pande, are you there?
Yes. Sorry. Can you hear? Can
Yes,
you hear
yes,
me?
yeah,
Okay.
yeah, we can.
Thank you. So yes, about how to record the result. This is a difficult question, actually, I believe. We in the past we've tried several methods. The first method that we test is to develop a website. So a website that where people can ask for the test. They could ask for the test, or we could send the kit after they register themselves. So they need to register their identity number. They need to register their phone number, not only one, but should be one and other, something their friend or their family that could be contacted. And then if they fulfill the registration well, then we could send the kit via Gojek, Grab, or by outreach workers. And then because we have the phone number, then we could follow up the result. But the client could also fill the result by themselves. So they could continue to fill the website by themselves. But if after, for example, we put about 2 weeks, for example, about 2 weeks, we realize in the system they didn't fill the data or the result, then we will follow up via the phone numbers. So that's one of the strategy that we use to get the data from the patient, to get the result and to get the report. So the other strategy that also conducted from the other implementers is only to offer assisted tests. So not self-screening, because they bit worry about the higher number of loss to follow up after the test. So we are in the process of testing number of modalities at the moment, Mas Adi. So we are not really sure which method is the best to get the data from the patient. So we will need more experience. We need more strategies and to be tested, actually.
Yeah, certainly we need to explore as many modalities as possible to with this recording system that I think the country has been facing for, I don't know, since I remember.
Since 2018, I believe, we already test the self-test.
But of course, the room and the questions. Yeah. I mean, while for TBI. Yeah, thank you about the ART delivery, Dr. Yanri. I mean, you highlighted about the community, how we can expand to actually the leverage the community-based facilities to deliver the ART for the treatment tension or treatment at start. But I don't know, somehow the country still falls behind on this. Why? How do you think we can solve this problem, Bu Yanri? I mean, why it's so hard? Which is it is not rocket science. Yeah, silakan Ibu Yanri.
Thank you, Mas Adi. Before our session, I was invited by the Atmajaya. We had a roundtable discussion about about this, rolling out the ART in the community. Actually, community-based service has been in the air since I think 2010, 2009 at that time. I attended the meeting in Vienna at that time, and when I came back, I asked Naf, what do you think? At that time, she was the secretary of the National AIDS Commission. Yeah, she said that we just have to go in the public. Yes, we have to go into. So we have to define community-based services. Is it really healthcare facilities, or it can be non-health facilities? If it were healthcare facilities, is it puskesmas enough? That's kind of the question. We have more than 10,000 puskesmas. Is it enough to be just in the mainstream of healthcare services? Maybe the country should also see access as well. In terms of maybe one region is so big that everyone has to go into one puskesmas. They might have to expand it into what it's called the supporting puskesmas, like the puskesmas pembantu. This is what I mentioned earlier in the roundtable discussion. Can we move it further? I mean, close it to the one that is needed. So if that is the streamline of the healthcare facilities, but then we also can think about innovations. And this is what we did in the HATI study. We tried to model that we had a collaboration between Dinas Kesehatan with the Puskesmas and the NGO providing HIV service. At that time, we used Kabaya, the Transgender Community Center, and Festa. Festa usually has a regular testing on Friday. So at that time, our model is to have the Puskesmas coming to the LSM, to the NGO, to Festa, and to Kabaya, not only testing, but they should also bring the ARV in hand, because then the doctor can immediately, at that night, the one who is tested positive can come home with an ARV. So this is somehow we were trying to provide I don't know whether that's innovative. As you said, it's not a rocket science thing. It's just connecting dots. Oh, you have this, and why not use it all together? So it's kind of this. So it's the willingness, it's the courage to do it, to innovate. I think that's what we have to push, because when we try to put that in place, our regulation is like this, the regulation is like this, ARV has to be provided by the pharmacist. Why can't doctor provide it? Why can't doctor dispense it? Yeah, because there's a regulation on this. And then also the recording. How are we going to record into the Puskesmas system? Blah, blah, blah. And then finally, we find a way at that time. But it turns out at the end of the study, when we try to advocate the district, blah, 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 they don't really pick it up as something that is, as their service. Yeah, it's kind of like that, I don't know where it is, where the hurdle is, but that's the condition.
Yeah. Thank you, Yanri. So I think we do have some models that actually we can leverage in the country, and I think it's about how the health system in Indonesia can be more open-minded, right, about accepting the system and also the regulations that perhaps and more discussions with especially the government. I think we can follow up.
Adapting it as such that it is feasible to be conducted so it's much suitable for the ones that is needed, so to say.
Yeah. Thank you so much. Yeah, thank you, Bu Yanri. We have one last question. I think this is for Prof. Kaldor. I really like your how to say you said yourself controversial idea of having this PrEP for the STI and also the mass drug administrations to control STI, then which in the long run will also helping for HIV, not also STI itself. But for Indonesia context, Prof. Kaldor, I think Indonesia is not really a good an early adopter into new methods, including for preventions. And now we are dealing with PrEP, which slowly progressing, but progressing. But how do you think, in your opinions, to what extent Indonesia can leverage the opportunity, although controversial, and what we should prepare to then be to accommodate these new ideas, especially to for the STI interventions? I hope that's clear.
Yeah, no, it's a good question, and so it takes us back to the issue about how common some of these STIs are and which are the most affected populations, because the value of these strategies is very much related to the prevalence or the incidence of STIs. So you have to make sure that it's a very high incidence or high prevalence setting to justify that. So my sense from Indonesia, as I mentioned before, it's as we are aware, one of the big issues for Indonesia is the low rates of antenatal syphilis testing. So I think that's where it's more important to put the efforts of innovation. In fact, I think we're collaborating with some colleagues in not too far from you there to try to look at programs to enhance the uptake of antenatal syphilis testing. And so we can use these technologies or these ideas in those settings. I think is much more, there's probably a greater need or a greater potential benefit in the immediate term. However, if there are populations in which the STI incidence is very high, and these may be some of the same populations at risk of HIV, or it may be some other potentially ethnic or linguistic groups in different parts of the country where there are high levels of STIs, then you may want to consider these controversial strategies. But if in doing so, it's something which is very much relying on community engagement. So if you want to introduce something controversial, as I think we all know the risk, it's got to be very much in a partnership or in the collaboration with those affected communities. So I think it's a question of, as we use the English expression, horses for courses, or choose. You've got to find the right context. But I think and it really again reinforces the importance of good data to see where the problems are, so you can target the hotspots. Thanks.
Thank you so much, Professor Kaldor. And you really highlight, I think, one aspect that was highlighted also by Prof. Pande and also Dr. Yanri, the significance of community engagement. If we would like to really address all the gaps in HIV response, especially for expanding the HIV screening facilities. One of those with the community-based service, and also what Dr. Yanri said about the RT delivery, that we do have some models, and then the question is how can we adapt this, and which of course the main component is to make sure the community engagement is placed with the right portions in the discussion and also the program development. I think that's more or less summarize what we have today. We do have more questions that we can address, but I'm sure that the organizer will help in conveying all the questions to the respective speakers, and will be addressed in some other way, email and everything by each of the speakers. Again, thank you so very much for your time, Prof. Kaldor, Bu Yanri, and Prof. Pande. And yeah, I'll see you again, perhaps in other opportunities. And for all the participants, thank you for your kind attention, and apologize for not being able and respond to all the questions. I think that's all the symposium 2 on HIV. And with that, I would like to give the floor back to the organizer. Thank you. Good afternoon, and Thank you very much.